effective case conceptualization, informing the care pathway, and setting the foundation for successful utilization management review. My name is Brianna O'Connor. Before we get started, I do want to remind folks, in case you just joined, if you could take just a couple of minutes during my introduction slides to follow the link either on the slide you see right now or it's over in the chat box and will remain there. It's just a few questions, I think 5 or 6 short questions that will really help us understand how the material is useful to you and how we can develop content that is more useful for you in the future. And we'll ask you to do a few questions again at the end, but that is built into the presentation today, so we won't be taking any more of your time. So we're trying a new method here of trying to get some evaluation feedback of doing it in the actual webinar. So please feel free to multitask and head on over and do that for a couple of minutes while I introduce myself. Again, my name is Brianna O'Connor. I'm a senior consultant at Coordinated Care Services Incorporated in the Center for Collaboration in Community Health. Most of you are probably very familiar with the Managed Care Technical Assistance Center, or MCTAC, but we are a training, consultation, and educational resource center in New York State, and our primary goal is to help prepare providers with the transition to Medicaid managed care. MCTAC is primarily composed of the McSilver Institute for Poverty Policy and Research and Casa Columbia, but there are a lot of partners throughout New York State. Specifically, as I mentioned, I am with CCSI, and I am a clinical psychologist licensed in New York State. My background is primarily in researching mental health outcomes and dissemination of evidence-based practices. What we're going to be talking about today, this is the first in a series of webinars that we have prepared to bridge the gap between effective clinical practices and utilization management, and show how there really isn't as much of a gap as perhaps some folks might think, and to try to really build up some concrete strategies to integrate the two. There are, over the course of the next few months, as you saw on the calendar, there are 6 content topics we'll be delivering, and then there are also 6 applied learning discussions on 3 weeks. Those are going to be specifically walking through a case example. It'll remain a consistent case example over the period of time, but looking at how to do some of the topics that we talked about in the webinar, how to apply that to a specific case. Those applied learning discussions will be held specifically focusing more on an OMH population and then also specifically on an OASAS population, so that you can choose to attend either or both depending on your population served. We're hoping that this series provides a training resource for new providers as well as professional development that, again, integrates these somewhat new utilization management requirements with effective clinical practice that helps enhance outcomes for patients and clients and consumers, and also streamlines the process. In part of our preparation for this series, we have actually contacted several representatives that MCTAC works with from managed care companies. So a lot of the information in here is the most up-to-date information that we have about what they think that, or what they're looking for, what they're struggling with, and what information would be most helpful. So we're hoping that we're giving you the most up-to-date information that we have. I'm going to make just one last plug for our evaluations. We are very interested in your input. We want to know what's helpful for you, what we can do better in the next webinar, in the next series. So please, if you have a moment, if you haven't already, navigate over to the survey that's on the right side of your screen there in the chat box, and please fill out those couple questions for us. All the information is de-identified. We're interested only at an aggregate level of what we're getting, how we're doing for you. Also, a couple quick points of business. If you have questions throughout this webinar, please feel free to chat them. We are planning to collect all of the questions from this webinar and next week's webinar and integrate them into the applied learning discussion the following week, and that'll perhaps be the pattern. If that doesn't seem to work, we can revise midstream, but that's the plan for now. So please feel free to link any of your questions over to the chat box, and at the end of this slide, there's also an email address that you can send any additional questions to. Finally, these slides and the recording of this talk and all of the webinars in this series will be available on the MCTAC website It'll be under the Learning Communities tab. They'll be posted as soon as possible after each webinar. So even though the webinars build on one another, if you have a conflict one week and you can't attend, but you want to keep up for the next one, you'll be able to do so. You're also welcome to share them with others at your agency. So for this webinar, we're discussing case conceptualization, and the learning objectives are here for you. I'm going to give a very brief overview of the utilization management process just to provide some context for the discussion we'll be having. We'll talk about some components of effective case conceptualization, talk about the integration of how case conceptualization can enhance client outcomes and also integrate with those utilization management requirements. And throughout the presentation, there are several resources for you about further details about utilization management, or and also case conceptualization. And we'll end with a few concrete next steps that might be helpful. Again, this is a very brief overview of There's far more information available for you that's much more specific, much more detailed, and is the most up-to-date resource we have on the MCTAC website, as you see at the bottom of the slide. So I encourage you, if this is your first introduction to or you want more specific details, to please go visit those resources because they'll be much more thorough. Utilization management for the purposes of this webinar is, broadly, it's the process by which an MCO, managed care organization, or managed care company decides whether a specific service or a specific level of care is the most appropriate for a particular client or enrollee. The goal is to be cost-effective, also make sure that the services are necessary and appropriate for that particular individual. And the long and short of it is that utilization management is required for reimbursement for many providers now and many more soon. But the goal is also that utilization management done well, done effectively, is intended to be very consistent with optimal care for clients and consumers. That's a little bit what the goal of this series is to describe this alignment as how to align this effective clinical care in the requirements to really enhance outcomes. Importantly, what's not listed here is that is not intended to deny services or to end services, and the managed care representatives that we talk to have frequently wanted to make sure that we clarify that the goal is not to cancel services for anyone. It's really just to verify that they're necessary and appropriate. And we'll talk more about that shortly. A little bit of terminology that is helpful as a background. Again, I'll go through this briefly for many of you. This might be review. Again, I'll point you to the resources at the top of the screen there. There's a lot of detail there that's very specific to programs about what specifically is required by which managed care company down in the city. So I encourage you to navigate over to those resources as well when you have a chance. For our presentation, we'll be talking mostly about prior authorization and concurrent review today and what applies there. Prior authorization is a request by the enrollee or on their behalf by a provider for a new service, whether that's within for a new authorization or within an existing authorization period, and it needs to be made before the service is provided in order for reimbursement to occur. An important note, outpatient mental health office and clinic services right now do not require prior authorization for the first 30 visits, or I believe it's 30, and that includes psychosocial assessment, individual, family or collateral and group therapy, and medication treatment. So those services don't currently require prior authorization. Concurrent review is the process where there needs to be extended treatment, so it's for continued, extended, or additional services beyond the initial prior authorization request. That would be during the ongoing course of care. That's ensuring that treatment remains appropriate for the individual. Obviously, discharge review is the process of ensuring that there's a plan in place for discharge so that the person has a safe transition and reentry to the community or step down in level of care. Retrospective review refers to either on an individual or aggregate basis a larger look back about the service. Outlier management is a terminology it's not very well defined yet. The managed care companies themselves are still trying to work it out, but providers are going to be responsible for looking at their outliers. Outliers refer to individuals or services or groups of providers where there might be some potential over or underutilization. And again, I want to reiterate that the goal is not to end the service, but to open a conversation about what might be going on there. For example, if there's low underutilization, there might be a conversation about assessing the barriers to engagement or treatment and assess progress and see if there's a different way to approach the case. On the flip side, if there's high use or overutilization, it may be that the level of care is inadequate. There needs to be a step up in level of care. The treatment plan may need to be adjusted, or there might be alternative approaches that might be a better fit and have better outcomes for a patient. So outlier management is really about opening a conversation about what's going on for that patient or group of patients and what can we do to better address their needs. Again, some of this is directly from some managed care companies about what they're looking for when the initial case conceptualization is shared. Obviously, there's some information that's always important, the demographics, the diagnosis, background, et cetera. Particularly relevant here is that the diagnosis is relevant to the service. So, for example, if seeking a substance use service, a major depression diagnosis would not be sufficient. However, an alcohol dependency with major depression would. So it's a little bit of logistics, but it's very much about identifying what's the need for this particular service and being very specific and individualized about that. Another big picture question that MCOs are looking for is, what are the clinical markers that dictate the necessary level of care? What did the psychiatric evaluation show? What are the individual's psychosocial needs? What kind of response have they had to previous treatment in lower levels of care? And what are their recovery goals? That's the big picture question. There are some specifics that they know that, especially for the levels of care that we're talking about today, PROS, ACT, and substance use care, that there are some flags that they would be looking for that are listed there for you. Repeated use of crisis services, difficulties or noncompliance with lower levels of care, answering that question, why didn't it work before? What might be needed now? Difficulties with medication, taking and adhering to their medication regimen, challenges to housing, and obviously co-occurring disorders or co-occurring substance use disorders are definitely things that they'll be interested in hearing about in the initial case conceptualization that tells you why this service should be authorized. Another thing that they might be looking for is that proactive crisis plan, if it's relevant, looking for warm lines and natural supports, and if there has already been any emergency room-based care coordination. A couple of specifics for the programs that we're talking about today. So for PROS and ACT, they recognize, managed care companies recognize that this is a higher level of care, and so they want to know the answers to some of these questions. Why this service for this program? If they could be managed in an outpatient clinic setting, obviously why would this be necessary? So it's describing why they are unsuccessful in that setting. Or on the contrary, is health home care management sufficient for their needs? And specifically, what will be accomplished with this level of service? For substance use disorders and substance use treatments, the locator tool is necessary for determining the level of care. It is required at admission and also at change in level of care, and it could be required at concurrent review if the level of care is in question. For the locator, and again, there is far more information on the MCTAC website about the locator tool, but the locator is required within 24 hours of admission or within the first 3 visits. There's no similar standardized tool currently for more OMH-based services. Again, MCOs are looking for information about outliers as appropriate, so they expect providers to be prepared to answer questions about it. However, it's understood that a small proportion of clients will require services for extended periods of time in order to remain stable, and so that will be naturally part of the concurrent review, that some patients just need a higher level of care for a longer period of time to remain stable. And what they're looking for there is the clinical justification, the evidence for why that is the case for this patient and how it's benefiting them. Moving now into specifically some features of effective case conceptualization that we'll weave back into the utilization management material. The definition of case conceptualization is a process whereby therapist and client work collaboratively to first describe and then explain the issues a client presents using theory. Its primary function is to guide treatment in order to relieve client distress and build client resilience. So taking that definition, it's essentially the foundation of evidence-based clinical care. We'll talk about it today in two places. So it's, on the one hand, it's a data collection mechanism to generate hypotheses about what's going on for a particular client, to then identify what we can do for that particular client. I'll be walking through a specific example of how to present a case conceptualization or think about it, called the 5 Ps. And it's also, case conceptualization is also it's a synthesis of what's going on, the client's history, their experience, their strengths, also existing theory and research and assessment to best identify the interventions and the goals that will help the client to reach the best outcomes and get on the road to recovery. In addition to a more foundational understanding of the client and their needs, there are many important functions of case conceptualization. Many of these are actually supported by empirical studies as being helpful, importantly, to enhancing client outcomes. So case conceptualization, in addition to synthesizing the client experience, can help normalize the presenting issues and be validating for that individual, especially when shared in a iterative way and feedback sought from the client. It also promotes engagement, particularly focusing on strengths-based approaches. The case conceptualization provides the opportunity to identify the client's strengths, places where there's already some resilience and where that can be built up or enhanced. And it also makes what can often be numerous complex issues that are brought in more manageable and more focused. The ultimate goal of selecting appropriate interventions that will have the best impact for the client, also perhaps be the quickest, the simplest, the most cost-efficient for everyone involved. Appropriate case conceptualization allows you to perhaps anticipate problems that may occur, perhaps offer potential reasons why an intervention isn't working, and suggest alternatives that may be tried. When done well, it also enables high-quality supervision because there's a shared understanding of the what and the why, and therefore which interventions to try or why they might have failed. And it also fits within the state's overarching goals for healthcare reform, which are to improve care and reduce cost. So as I mentioned, I'm going to walk through the 5 Ps of case conceptualization. There are a lot of different models of effective case conceptualization. However, I just chose one and I integrated some elements from others just in the sake of parsimony. And because, we're MCTAC and we're CCSI, we like acronyms and mnemonics, so I thought the 5 Ps was most appropriate for us. So I'm going to walk through each of these 5 factors and steps with some examples and specifically about how what the managed care company wants to know integrates with that factor. And it's building on good clinical care. So a lot of these things are already done in settings where they're doing clinical work, and really just trying to show where are some opportunities to enhance the effective clinical care to also meet the needs of the managed care company and build on that information that they're looking for that is required and necessary. So first is the presenting problems. The first step when anyone walks through the door, of course, is to identify what's the issue that they're coming in with. What is the problem, including the severity and any challenges to their daily life functioning or impairments the problem is causing. This wants to answer the question, beyond just the diagnosis, how is the person's life affected? Here, obviously, is where there's also a risk assessment conducted. It's important to collect information about a lot of different factors and features of the presenting problem, things that might cause it, maintain it, make it worse, or even make it better, make it relapse, or just lessen a little bit for the individual. There are a number of factors that can be explored here, including culture, religious identity, acculturation, gender-related factors. referring to the bottom of the slide there, the DSM-5 cultural formulation interview has a lot of really good questions to get at some of those issues that I strongly encourage you to check out. Also important about the presenting problem is to start to quantify and operationalize the issue. So what is the specific impact on the patient's thoughts, mood, behavior, and how can we identify those things in concrete, measurable terms? These set up treatment and recovery plans that are very specific and progress monitoring that will help identify how well the goals are being met over time. There's also some evidence that you can build optimism in a client if there's some initial goals met early on, so having measurable, very specific targets for the initial phase of treatment can help build optimism and build kind of momentum for successful care. Another resource down there for the rating scales and standardized interviews that can really facilitate this conversation, and by facilitate I mean speed up. I know assessment is often a time-consuming process, but using some, in populations where it's feasible, using some rating scales or some standardized questions can really help target the conversation and target the questions that need to be asked and make the process a little bit more efficient. And there are some resources on the MCTAC website, the Output to Outcomes website, about specific questionnaires that might be helpful to your population. Here, what the MCOs want to know is that basic information that we know we have to report, demographics and diagnosis, but also what are the individual's needs? What does this person need to be successful and feel like they're moving towards recovery? The next P is the predisposing factors, and this is essentially the history and the background. What has the person tried before? What treatments or interventions have been tried, and what were their outcomes? What worked, what didn't work, and why? Any current methods of coping are important to describe from an MCO perspective. If there's a mental health issue as the primary issue, are they using substance use to cope? Are they using crisis services, ER, inpatient services? Are they just failing to attend treatment? Those are really important to the managed care company for identifying why this level of service is necessary for this person to be successful and moving towards recovery. This is also where some of the basic background factors are important to document. Medical history, including current medications that are not just behavioral health specific, but all medications, physical health conditions that might be playing a part in symptoms and functioning for the individual. Family history that may predispose a person towards certain symptom clusters, and then if there's any intoxication or current withdrawal symptoms that could impact treatment and care. Again, some environmental factors are listed there. I won't read them for you. It's important to look at the whole package of the individual and what might be influencing their symptoms, including housing is important, finances, psychologically, whether they have positive or negative coping strategies, whether there's a lack of insight, and so that's why this level of care might be more appropriate for them. Their cognitive style indicates it. And then interpersonal factors, family dynamics, peer relationships, romantic relationships, and on the flip side of those things, also lack of support from some of those relationships. And here the MCOs want to know, why is this treatment necessary? What else has been tried, and why wasn't it sufficient to help this individual? Next up is the precipitating factors, and this is more contextual information, the where and when this presenting problem or these presenting problems occur. Are there significant events that happen just before the onset of the disorder or the episode or the presenting issue? If it's a mental health, is it substance use that's preceding it? On the flip side, if it's a substance use issue, is there a mental health flare-up, a mental health relapse, or a physical health relapse or issue that precedes the onset of the substance use? Other common precursors are, interpersonal distress, legal issues, losing a job, again, physical health issues, financial stressors, housing, all things to consider and things to document for the MCO. And this is, again, the precipitating factors is similar to the antecedents. What's happening immediately before, and also a little further back, what's preceding it, and then what's immediately before it, if those are relevant to the issue. Here, the MCOs want to know what prevents this person from being successful at a lower level of care. Again, it's about justifying why this service for this person at this time is the most likely to help them towards recovery. So next P is the perpetuating factors. And these are the factors that might be maintaining those current difficulties, or in behavioral terms, consequences. This could be ongoing substance use. It could be some behavioral patterns that we know are associated with difficulty changing symptoms. So avoidance in an anxiety disorder, withdrawing from social situations in depressive disorders, and stimulus control and substance use, still hanging out with the same source of substances and not changing that pattern. There are also biological patterns that are important to think about, not just as symptoms, but as factors that might be contributing to symptoms. For example, disrupted sleep or eating behaviors that might be causing some of those challenges for the individual. Certain cognitive patterns that we're probably all very familiar with have an impact and may be important to document. A memory bias towards depressive events or negative events would certainly be a concern for perpetuating depressive symptoms. Similarly, interpersonal stressors, if there's a relationship, either with a romantic partner, with their own children, those are some factors that may be perpetuating the stress that's leading to this individual needing a little bit more support. And again, I just want to point out, these are examples in all of these 5P sections that can obviously fall into more than one of these categories. This is just one way to organize them. So certainly there's going to be overlap among them. Here, what the perpetuating factors is getting us towards for the MCOs is what will be accomplished by this treatment. What about these patterns can this treatment help to address and change to help shift the course for this individual? The final P is a very important approach. It is the protective and positive factors. So this is the strengths-based approach. What are the strengths and supports of the individual that might mitigate the impact of those presenting problems? How have they been able to cope already in the past to get to this point? It may be specific social supports, maybe skills the individual has, personality characteristics. And the focus here is on recovery and wellness, identifying what those resources are that the individual already has, what those natural supports are, and then building on them for developing a recovery plan and some specific goals for treatment. There is some evidence in the empirical literature that including strengths-based approaches not only reduces symptoms, but also improves resilience and can contribute to client optimism about their course of care. And I will begin to plug for us. The webinar series actually includes, in January, there's a webinar on family alignment that will go into a lot more detail about identifying and relying on those natural supports. Here in the protective and positive factors, the MCOs want to know, how does this treatment fit into that client's bigger picture of recovery and the other services that they need to receive or need to be set up for? So what's the big picture for this person's recovery, and how does this fit in, this particular treatment at this time? So putting it all together, once the information is gathered from all of the 5Ps and other sources, other resources, there are certain things that have to occur and that can occur to provide a more parsimonious case conceptualization. Obviously, first, there's no getting around that a diagnosis is required for services. But for those who are, a little reluctant about diagnosis, or who think diagnosis is a little antiquated, it also can help identify those appropriate assessment and treatment strategies that might exist. There's literatures out there about diagnoses from many, many decades of work. So putting a label can help identify and help kind of focus searching for what is the next best assessment, what is a treatment strategy I haven't tried, what else can we do to help this particular person. Putting all these pieces together is also where to start looking at and thinking about, how do these presenting problems relate to one another, if at all? but what is the play between them? If we approach this presenting problem this way, will it have a negative impact on other presenting problems? Or will it also help that other presenting problem? And thinking about the pieces together in a web that is integrated. It's also important, case conceptualization, after collecting all of the data, to start to generate hypotheses. How will you know if treatment was successful? How will you know if treatment was unsuccessful? It's often, I think, a neglected piece that we focus on the success of treatment and the improvement, but that's not always the case, and that's often not the case right away, that we don't get the right treatment lined up for the right person. So we need to be careful about saying what will be an indication of the treatment being unsuccessful so that we know to change course or change treatments or change approaches. It's, again, important that these hypotheses are very specific, operationalized, measurable, testable. Particularly from an MCO perspective, it has to be clear in the documentation what is the hypothesis about why this presenting problem is an issue, and what is your specific hypothesis about why this treatment will address that presenting problem for this person, and how specifically that will lead to their recovery and their improvement. Often these hypotheses lean on theory-guided targets, so they lean on the existing theory for these treatment goals, but again, it's important that they're not just theory-driven, but theory-guided, so that they are also very specific and individualized to the person. It's an incredibly important piece, both clinically and also as far as an MCO is concerned, to make sure that the patient or the consumer is included in the discussion and not just presented the case conceptualization, but that it's a conversation with the person about the conceptualization. They understand the conceptualization, they agree with it. If not, you get feedback about what areas they think are not quite accurate, and that you then take that collaborative discussion and prioritize presenting problems. We all know most clients have more than just one simple stepwise, this presenting problem and then this one. So you want to make sure that it's a collaborative process to prioritize which to address first based on what does the client want to address first, what's most important to them in their life right now. The client is also a really great resource for figuring out how should we monitor progress towards this goal on the treatment plan. How will we know if we're reducing this presenting problem, this symptom, this issue? How will we know that your daily life functioning is improving? How should we measure that? When should we measure that? What should we do to measure it? The client is the best resource for that in a lot of ways. Client engagement is actually a webinar that we'll be hosting in January that will go into much more detail about that process and how to really engage with the client in a way that helps set up treatment for success. Obviously the main purpose of the case conceptualization is to figure out how do we treat this person in a way that is most helpful for them. So developing that treatment plan or that recovery plan, treatment goals, recovery goals, all those terminologies get at the same concept. Which evidence-based practices are indicated for this presenting problem? Here again is where that diagnosis can come in handy, but also it doesn't have to be diagnosis specific, it can be presenting problem specific. Developing the treatment plan based on the case conceptualization helps to identify where can we have those, as I mentioned, those initial successes that build on the individual strengths that will help build that momentum for treatment. Also within the case conceptualization, the treatment planning, even that very initial assessment is where the discharge plan and the discharge criteria should be beginning to be brought up and beginning to be in your mind. It's important that this process begins at the initial visit and is part of your conceptualization because you want to conceptualize recovery as the goal. So how do we get there? What's the road we have to follow to get to that recovery end goal? And again, end goal is a misnomer because it's really about planning for the next step. What is the next step down? What is the next step towards community engagement? Are there other services, natural supports that this individual needs to be lined up with at discharge? And how do we work towards them? And that's where it's important to start thinking about discharge initially so that your treatment plan is built on how to get there specifically. Clearly articulating goals and treatment plan, which will be discussed in far more depth next week at our treatment plan and outcomes webinar. But clearly articulating those goals sets the stage for this time-limited, recovery-oriented intervention that is both better for your organization because it frees up more providers to provide more services for more individuals. It's better for the client most of the time because they are moving more towards recovery, and it provides a more cost-effective service as far as the MCOs are concerned as well. Here at this phase of putting up all of the pieces together, what the MCOs want to know is, what are you going to be looking for? How are you going to know when a goal is achieved? How will you know when it's been accomplished? How will you know when there's progress towards it? This is why it's important to really operationalize those hypotheses and those goals so that it's clear what success looks like, or clear what lack of success looks like. It's not subjective that the client feels that they're doing better, but it's documented. We can show that towards this goal, the client has made 20% and then 40% and then 80%. That really specific, testable amount of goal being accomplished is really important to MCOs. Though there will be more discussed, again, in great detail about documentation at the webinar in December, I did want to make sure to point out here that documentation of everything we've just talked about, the case conceptualization all the way through the initial discharge planning, treatment goals, everything needs to be documented, because if it isn't documented, it didn't happen. And that is unfortunately a phrase that you will hear repeated and was given to us also by the managed care companies, which we can understand. If we can't document that something worked, or that we tried something, or that we had a conversation, there's no way for them to know that it occurred. So documentation of your logic, your hypotheses, the data you collected, and the rationale for why this service, the clinical justification for the service, is essential. A couple of other points about documentation. With the exception of the locator, there's not really a standard format at this time for what managed care companies are looking for in terms of what that initial assessment or treatment plan, or even, again, with the exception of locator, what that evidence of need looks like. There are some tools that exist, but there's not really a standard format. They may develop one, they may not. Obviously, MCTAC will keep you updated if any of that occurs, but at this point, it's mostly this clinical information and just documenting it carefully. There's not a specific way to document for specific services. Since there isn't a standard format, we wanted to provide a couple of quick tips for how to document some of this information. Again, more detail will be provided in December at that webinar, but it's important to document engagement of the client in the goals, in the conceptualization, in tracking and monitoring progress. Client engagement, patient-centered care is a really important component of this healthcare transformation. When monitoring progress, whether that's progress towards goals, symptoms, functioning, employment, it's important to use consistent data elements or consistent pieces of information over time across your sessions. If, for example, if you're looking at a symptom measure, but you use, for depression, for example, but you use the PHQ at the initial assessment, and then you use the BDI at your 6-month session, you won't be able to compare. It's apples and oranges, essentially. So it's harder, makes your job a lot harder to track progress over time. And similarly, from a program perspective, if you have multiple individuals receiving the same service, it's a lot easier to look really quickly at how a particular service or program or clinic is providing services, how the progress of that population, that aggregate group of people, if it's the same type of data being collected about those individuals. You know, this doesn't run counter to the individualization piece. It's more about, you know, if it's individualized goals, it's about tracking goals in the same way. So the treatment can still be individualized, the goals can still be individualized, but the data that's collected across time is more consistent, so that it's easier to draw conclusions about large groups. If at all possible, where at all possible, what's called discrete or continuous data, essentially numbers, is a lot easier from a program perspective and a lot easier even over time within one individual than free text or what I know as psychologists we love to use the other category. Those are very difficult to look at quickly over time. Obviously there has to be free text in some of your notes and your treatment planning, of course, but the more consistent that can be, the better. But again, if there are ways to measure progress in a numeric way, so that, for example, you can track a chart to show your client, here's the progress that we're making, it's a lot easier than to say, well, several sessions ago I wrote down this and now I'm writing down this, so it looks like we're doing better. Obviously we have to write the free text. We love to write notes, maybe not love, but we do write a lot of notes. But wherever possible, if there's ways to streamline data collection to use number data, it's a lot easier to draw conclusions over larger groups and over time. Again, another piece about operationally defining what it is that you're looking at, whether it's your case conceptualization, your tracking over time. Think about it as a fly on the wall or audit mentality, whichever sounds more appropriate to you. It should look like anyone who reviews your conceptualization, your treatment plan, your data, will come to the same conclusion that you did because it's documented so specifically and so clearly. Everyone will know what your goals were, how you plan to measure them, and when they will be met because it's very clearly articulated. From a numbers data perspective, this would mean that anyone who looked at your aggregate data about your clinic's overall percentage of individuals meeting a particular treatment goal, everyone would calculate the same percentage because you very operationally defined the information. That last point there is just about progress versus pre-post, and this is just to get at, mental health and substance use are very changing constructs, and so measuring something perhaps, and this is very individual to patient and, or to client and service, but measuring how someone's doing every 6 months may not be a good way to measure. If you're looking at that in a pre-post way, it might not be a good way to measure what's really happening because maybe within that 6 months there was a period of relapse or a period of recovery that if you're not documenting when that action's happening, when that change is happening, you'd miss the opportunity to build on it or to address it. Final point about documentation is that this documentation needs to be shared. Importantly, again, in patient-centered care, that documentation needs to be shared with the client so they can provide insight about a bad week, a good week, how they think things are going in relation to your tracking and your monitoring. Obviously, the MCO needs to have information shared. It's also important to share this documentation with other supervisors, other members of the care team, the care manager, if it's applicable. And this sort of documentation is building the foundation for moving into value-based care, where it's going to be essential to show documentation of how this service helps these individuals in this way, very specifically. Technology can be incredibly helpful for this documentation, and it certainly facilitates it, but it is not technically necessary in many cases. So just because perhaps your organization doesn't have an EHR, it doesn't necessarily mean that, or does not mean that you should not be documenting in whatever way makes sense for your organization. Again, this will be just a brief overview about supporting case conceptualization from a supervisor perspective because we do have a webinar coming up about effective supervision, clinical supervision in the world of But particularly related to case conceptualization, there's evidence that using concrete strategies such as concept mapping or chalkboard case conceptualization, which I provided a reference for, using those concrete strategies actually increases the reliability and validity of case conceptualization among trainees. So there may be some benefit to using some of these more concrete strategies if you're a supervisor to helping your supervisees become a little bit more efficient, a little bit more reliable, and coming up with stronger case conceptualizations. Obviously, conceptualization is an evolving process, so as a supervisor, it's important to remember that you have the information that you have at assessment, and then, of course, you get more as time goes on, and so conceptualizations should shift. And it's important to also communicate that to the MCO if that occurs. If you get a piece of information that helps you have an aha moment or helps you redefine why treatment needs to shift in this direction, documenting that is important. There are existing data sources that can help facilitate this process. I know that as a provider, you don't have all the time that you want to have to come up with a really snappy, jazzy conceptualization. You have the time that you have. I understand that. But making use of existing data can really help. There might be other assessments within your organization if this is an ongoing patient that's sort of coming back for a relapse, or other assessments from other organizations in your community. The care manager, if the client has one, often has a lot of information for you. And then there are other broader statewide tools or regional tools or organizations, psyches, the LGUs, and there's others in your community that might be able to provide you some data that would help you know perhaps service use or other utilization about your patient to know, or your client to know if there's something that you can do differently. Of course, it's important to think of the conceptualization as just the initial step that starts to build a data feedback loop. So you're going to be tracking whether these adjustments need to be made, how they need to be made, and it's an evolving process that really needs to include the client. And it can certainly include the MCO if necessary. The MCOs want to be a partner in care also. A couple final notes here about how to share this initial case conceptualization with the MCO. It's important that the person communicating is prepared. Ideally, the clinician is on the call with the MCO to make that initial prior authorization or that concurrent review, because they are the one who's best in a position to have a discussion about the case. If that's not possible, if you have a utilization management liaison, or if, worst case scenario, you have to have someone, from the front desk, which is not ideal, it could be still possible as long as all the information is available, is prepared, and is very clear. Obviously, just engaging in a discussion of a clinical care of an individual requires a certain level of clinical understanding, so a clinician is the ideal candidate for that. MCOs also are interested in having that initial call, those initial calls, all those conversations, having providers identify who else is involved in the care for this person. Do they have a primary care doctor? Do they have a health home? Do they have a care manager? When was the last time they saw their doctor or their care manager? Those types of questions are important for them also. Finally, it's very important to managed care companies and, of course, to effective care that conceptualizations that build into treatment plans and treatment goals are person-centered and individualized. So it won't work to call up and ask for 6 months because this person has this diagnosis and that's what we typically ask for. That's not going to fly anymore with the MCOs, because it has to be, well, why? What is it about this person that he or she needs this treatment for this length of time? Similarly, and again, as a provider, I share the burden of clinical notes. If you have 10 patients, you can't have the same note for all 10 patients. You can't have the same note for one patient over 10 sessions that's just copied and pasted, because the managed care companies are going to start looking at that, and they're going to start calling and saying, hey, what's happening here? Obviously, this doesn't indicate that you're individualizing care to this person. So that's on this slide here. What the MCOs want to know specifically is, how is your treatment plan, your conceptualization, your thinking about this case, how is it individualized and how is it person-centered? And it's very important that that's clearly documented. I do have just a couple more final slides, but I know that some people need to get off to prepare for their next appointment. So I'd like to encourage everyone to please take a few minutes while I'm wrapping up to follow this link. It'll also be posted over in the comments in a moment to take our follow-up survey. It's posted there now for you. It's really important to us to get your comments and to get your feedback about how helpful this is and what we can do differently in the future. So please take a few minutes. All of your answers are de-identified. We just want to know at a group level what you guys are thinking. So please take a few minutes to do that. I do have a couple more slides, but I will get you out before 1 o'clock. And I, not so subtly, have put the reminder to take the survey down at the bottom of the last few slides. So again, in summary, there's a lot of changes occurring with this healthcare reform and the new this and the new that, all of these acronyms. But it's here to stay. It's going to help our clients in the long run, help us in the long run, but it is definitely here to stay. It may be pushed back, the dates may shift, but it's coming no matter what. Utilization management can sound like a burden, but really what it's asking for, what the requirements are, it fits pretty well within the framework of what we would expect for high quality care. You know, looking at why does this person need this service, for how long might they need it, what would we want to see improved, that's really just good high quality care. And the fact that we have to write it down in a different way or approach it, documenting it a little differently for the managed care company, maybe that part's the burden, but the actual goal of it is really in line with providing the best care that we can for our clients. I get that effective case conceptualization certainly can require a lot more upfront work, especially if it's a new skill. The goal is that, like a lot of these changes, it's a lot of work in the upfront, but in the long run, really having that quality conceptualization, that quality foundation will enhance engagement with the client. It will point you in the direction of the most effective treatments, interventions to try. It will improve some of those statewide goals of client outcomes, client satisfaction. It will more than likely reduce the cost of care and the length of stay, because if you can identify early on and go early on into the intervention path that is most effective for that individual, obviously they will be on the road to recovery sooner and need a lower level of care sooner. A couple of next steps, concrete next steps for your organization, if you haven't already done them, that might be helpful. Identifying someone to be the liaison between the managed care companies and your organization can be very helpful. That person can be responsible for collecting the provider manuals. Managed care companies have put out, many of them have provider manuals that walk through a lot more of this detail. That person, your liaison, can familiarize themselves with those terms, the expectations, and then disseminate that information throughout your organization. The MCTAC has done a lot of work with managed care companies in the state to align those expectations as often as possible, and they're very, very close. But there are a few differences. Again, those slide decks that I referred to earlier in previous slides on the MCTAC website, specifically about we'll go through the specifics of the differences and the similarities, but having someone in your organization who knows that can save your providers time from having to identify when and in which cases they have to do certain requirements. If you are a supervisor of fellow clinicians, consider incorporating some concept mapping strategies in the supervision that you provide to facilitate learning this, if it's a new skill for your folks, learning this in a way that makes them more efficient at it, and also facilitating that integration of ideas that helps promote the optimal treatment course. Again, a great next step for everyone here is to attend the upcoming webinars that we have and the additional related content. Next week is treatment planning and outcomes, and the week following that will be the case examples that will include both from case conceptualization through treatment planning for a specific case, one for OMH-specific providers and one for OASAS-specific providers. But of course, you're welcome to attend both if you'd like. The last piece is, even though I mentioned that technology is not required for this documentation just yet, for many providers, it is for some, I understand, but seek consultation and support if possible for enhancing whatever you currently have. It doesn't mean that you need, a $500,000 EHR, but it might mean that you can upgrade your system in a way that streamlines this documentation process so that it's not so much of a burden for your providers. Included here are just some of the references to the materials that I spoke about. Again, these will be posted so you don't have to jot them down right now. And finally, if you do have any questions, I do not want to go over 1 o'clock, and I do appreciate the time that you're taking to fill out that post survey. The link's over there in the chat box. But please feel free to send your questions to this website, mctac.info@nyu.edu. Use the subject line Case Conceptualization Webinar, and it will get over to me and the other team members who are putting together this information. We will answer all questions at the Applied Learning discussion that we're having on November 17th. The goal there is to obviously be mindful of your time and also make sure that we're providing the most up-to-date information. Of course, if it's more pressing, we will certainly get back to you. But with that, I believe that is all I have. Thank you all very much. Please don't hesitate to send over questions or comments, and I look forward to seeing your responses on the survey. Thank you all.